Hello, everyone. There's a couple questions in the chat, but I can go ahead and start and we can address those later. So I'm excited to be here today and to talk about risk-reducing therapies for breast cancer. This is also known as chemoprevention. The medications that I'll discuss, even though they're known as chemopreventions, are not chemotherapy from a pharmacologic standpoint. So the standard therapies for breast cancer prevention are anti-estrogen therapies or hormonal therapies. They include selective estrogen modulators, tamoxifen and raloxifene, and they also include aromatase inhibitors, anastrozole and exemestane. There is a third aromatase inhibitor. This is known as letrozole, but it's only FDA approved for breast cancer treatment. We are also offering at BPrep the TAM gel study. This is a clinical trial. It's currently closed and we're awaiting results, but we're hopeful to offer this option again in the future. So as I mentioned, our options for risk-reducing therapies include the serums and the aromatase inhibitors. And what we can offer women depends on their menopausal status. Premenopausal women are eligible for tamoxifen dosed at 10 milligrams or 5 milligrams. Postmenopausal women are eligible to take tamoxifen, raloxifene, anastrozole, and exemestane. So raloxifene is a serum like tamoxifen. So I think technically some people can use it off-label for premenopausal women, but it's currently FDA approved for postmenopausal women. So tamoxifen was FDA approved for breast cancer prevention in 1999. This was based on data from three important studies, the NSABP P-1 study, Royal Marshall, and the IBIS study. Yeah, I think we can go back a little bit. I'm still talking on the previous slide. Yeah, this one. And the other medications, raloxifene was introduced after the STAR trial. So raloxifene was compared to tamoxifen in the STAR trial for postmenopausal women, and the results were published in 2006. And the FDA approval for raloxifene as a preventative therapy came out in 2007. Exemestane and anastrozole were studied as preventative therapies later, and they can now be used for breast cancer prevention. So all of these medications have side effects. The one that stands out for most women is the fact that they cause hot flashes. So as a provider, the most concerning side effects with the serums include blood clots in the lungs and the legs. Blood clots in the legs are known as deep vein thromboses, and blood clots in the lungs are known as pulmonary embolisms. Serums are not a good option for patients who have a personal history of blood clots, a family history of blood clots, or who are non-ambulatory, because if people are wheelchair bound or using crutches, non-ambulatory, they have a higher risk of blood clots. They should also be used with caution in women who are smokers or significantly overweight, because those factors increase the risk of blood clots. Tamoxifen also has a small increased risk of uterine cancer. So I now want to present the data from the NSABP P-1 study. So this was the first breast cancer prevention trial. It was a randomized trial that enrolled close to 16,000 women. They actually targeted to enroll 16,000, but in the end, I think they only enrolled 13,000. They were randomized to take tamoxifen dosed at 20 milligrams or placebo for 5 years. The study period was from 1992 to 1997. At the time of the study, tamoxifen had proven efficacy for non-metastatic breast cancer, and they knew that it reduced the contralateral breast cancer risk. Tamoxifen was reasonably well tolerated, and lab data showed that tamoxifen could halt tumor pathogenesis. Women were eligible for this study if they were 60 years or older, or if they were between age 35 and 59 with a 5-year predicted risk of breast cancer greater than 1.66%, or they had a diagnosis of LCIS. The breast cancer risk was predicted using the Gale model. They needed to be healthy, without evidence of breast cancer, not pregnant, and they could also not be on hormonal therapy. And so breast cancer risk in the Gale model was determined considering the woman's age, the number of first-degree relatives with breast cancer, whether they had had children or not, and if they had children, what was the age of their first live birth, if the woman ever had any prior breast biopsies or a pathologic diagnosis of atypical hyperplasia. So women with high-risk lesions were included in the study, and that included atypical ductal hyperplasia, atypical lobular hyperplasia, and LCIS, because these lesions increase a woman's risk of breast cancer. In the Gale model, they also included the age of a woman's first period, since that's a predictor of breast cancer risk. So after 5 years of follow-up, tamoxifen was shown to reduce the risk of invasive and non-invasive breast cancer by 50%. So this was statistically significant. So this study was actually led by a very famous breast surgeon, Dr. Bernard Fisher. And as a result of these findings, tamoxifen for prevention allowed surgeons to avoid doing breast surgery. So this was a little bit controversial for him at the time that the study came out in 1998. So then in 2005, at 7 years of follow-up, the study demonstrated that 5 years of tamoxifen not only prevented breast cancer while women were on treatment, but also it reduced the risk of breast cancer after treatment had stopped. In the placebo arm over this period, 250 women had been diagnosed with invasive breast cancer compared to only 145 in the tamoxifen arm. So this brought the question about how long does the benefit of tamoxifen last? Is it lifelong? So we'll come to that later on in the talk. So the most serious side effect from this study was pulmonary embolism, or blood clots in the lungs. This was statistically significant since a 95% confidence interval is above 1. So for those of you maybe who haven't looked at medical papers, it's an important result if the confidence interval is above 1. So they also found that women on tamoxifen at an age greater than 50 were more likely to have a pulmonary embolism. So this means from a public health view, it is best to treat women with tamoxifen who are high risk for breast cancer in their 40s and 50s. They are more likely to benefit when they are younger, and they're less likely to have a serious complication like a blood clot. So following the NSABP P-1 study, a group in the UK did a similar trial. This was the Royal Marsden study. So it was similar to P1, but it included a slightly different patient population. And instead of 5 years of tamoxifen, they did 8 years of therapy. It was also a smaller study with only 2,500 women, and women could be on hormonal replacement therapy, which, I think for a lot of us, it's like, oh, this kind of seems to contradict hormone replacement therapy, but then they're also on an antiestrogen. So the antiestrogen tamoxifen acts at the site of the estrogen receptor. So it may kind of work together, but their results at 5.8 years actually saw no reduction in breast cancer. So this was in 1998, and it was controversial since it was published shortly after the P1 study. And since this was in the UK, we actually kind of ignored this in the United States since it was a smaller study than P1, and the women were on the hormonal replacement therapy during the study. Then in 2007, the Royal Marsden group presented an update, and in fact, there was a reduction in breast cancer in the study. They showed a reduction specifically in the estrogen receptor positive breast cancers, and that reduction continued after the 8-year treatment period. A third study then confirmed this long-lasting effect of tamoxifen for prevention. This was the IBIS-1 study, and it showed a reduction in breast cancer during the 5 years on therapy and then 15 years after therapy had stopped. Again, this benefit was primarily in reducing estrogen receptor positive breast cancer, which is the most common cause of breast cancer. So this is broken down where the placebo arm is in blue and the tamoxifen arm is in red. So at 20 years, the cumulative incidence of breast cancer for women who had been on 5 years of placebo was 12.3%. And in contrast to women who were on tamoxifen, the incidence was 7.8%. And then they further broke this down, and the dotted lines represent women who that were on therapy and the rates of estrogen receptor positive breast cancer. So this difference in invasive breast cancer is primarily because tamoxifen prevents estrogen receptor positive breast cancer. So after the tamoxifen versus placebo studies, tamoxifen was compared to raloxifene in the STAR trial. Compared to tamoxifen, raloxifene caused less endometrial cancer, less uterine hyperplasia, and less blood clots. So the side effect profile was more favorable. However, it was also less efficacious compared to tamoxifen in preventing breast cancer. There were then 2 trials looking at aromatase inhibitors for breast cancer prevention in postmenopausal women. They were both efficacious. This is the trial for anastrozole. This is the trial for exemestane. So when I talk in the clinic about these options, the biggest barrier for these medications is hot flashes. So we all have negative images of hot flashes. So my favorite picture here is the woman who has the volcano erupting, representing a hot flashes. Hot flashes can be daily and they can be debilitating. In regards to the other side effects, the blood clot risk with tamoxifen is low at 0.5%, and the endometrial cancer risk is low at 0.4%. So in contrast to tamoxifen, aromatase inhibitors do not have the blood clot risk, they do not have the endometrial cancer risk, but they can cause bone loss, and they do cause more joint aches and pains, so arthritis. So I find that aromatase inhibitors are often not as tolerable as tamoxifen. They do have good efficacy, and we use them widely for patients with breast cancer. However, in the prevention setting, I definitely find the serums more tolerable. So in all of these trials, these medications were not associated with an increased risk of coronary artery disease or strokes. There is a slight increased risk of cataracts with tamoxifen, but this is very intervenable with surgery. So with the cataract risk in the NSABP P-1 study, 27 out of 1,000 women with tamoxifen developed cataracts versus 22 out of 1,000 women who were on placebo. So the uptake of risk-reducing therapies is low. In trials, around 25% of women who are high risk for breast cancer will do risk-reducing therapies. In the real world, only around 8.7% will try these medications for preventions. Factors that are associated with a higher likelihood of trying a medication includes an abnormal breast biopsies. This may be LCIS or atypical hyperplasia. Women are more likely to try these medications if their doctor recommends it, which is good. If a patient also has a perceived higher objective risk of breast cancer, they're also more likely to try a therapy. And if they have fewer side effect concerns and are older in age. So in this context, a low dose tamoxifen study was actually started in Italy. So the study looked at 5 milligrams of tamoxifen compared to 20 milligrams of tamoxifen, which is kind of standard. And the idea to try 5 milligrams was because the thinking was maybe it would be more tolerable. And instead of doing 5 years of therapy, they decided to do a shorter duration of 3 years. Women were randomized in the study to tamoxifen, 5 milligrams versus placebo. They actually included women with ductal carcinoma in situ, which means that they had a higher chance of developing invasive breast cancer. So this was the study flow. So 253 women took tamoxifen for 3 years, and 257 were randomized to placebo. So note how this was approximately 500 women total compared to the original P1 study that had 13,000. So it's hard to make any like long-term conclusions when the study's smaller. So the low dose tamoxifen study for 3 years actually reduced the risk of breast cancer. This was a great result. Compared to placebo, women with tamoxifen had more frequent hot flashes. So you can see that on the next slide. So this is figure A up in the corner. So this was a significant result that women were more likely to have hot flashes if they were on tamoxifen, which is shown in red. They also looked at hot flash intensity, vaginal dryness pain, musculoskeletal pain. And even though you can see that there's a trend for more hot flash intensity reported with tamoxifen, it was not statistically significant. Similarly, the difference in the two groups, placebo and tamoxifen, for vaginal dryness and musculoskeletal pain was also not significantly significant. So as you can see, there are these reported side effects on the study. However, overall, low-dose tamoxifen was reasonably well tolerated. There were also lower rates of endometrial cancer and blood clots with 5 milligrams of tamoxifen in compared to the historic studies with 20 milligrams. So that there is interest in our breast cancer preventative clinic, the B-PrEP clinic, to look at other new novel approaches. And one of the studies that we've been offering is called the TAM gel study. This study is looking at tamoxifen gel in comparison to placebo gel. Women who have an increased breast density on mammogram are eligible for the study. So the idea is that tamoxifen as a gel may decrease breast density on mammogram and lower a woman's risk of breast cancer. Women are eligible for the study if they're between the ages of 40 and 55, or if they are less than 40 and they have other risk factors for breast cancer. They must have increased breast density by mammogram. This means a mammogram level of 3 or 4. So for this study, women apply the gel daily to their breasts for 1 year. This is an alcohol-based gel, so very similar to hand sanitizer, which we're all very familiar with these days. After application, women are encouraged not to shower or swim so the gel is not immediately washed off. It's actually kind of pretty simple in that regard. So women are then followed during the course of the study. They need to have a mammogram at the start of the study, then a mammogram 1 year later. And if they want, there's the option of having a breast biopsy that will be used for research purposes. So this study is currently closed, but we're hoping to see results soon. And we hope to offer this option again in the future. So in the B-PrEP clinic, women with high-risk lesions are taking risk-reducing medications. Approximately 18% are on these therapies, and there's a higher uptake of women in their 30s. This is good news because when women are in their 40s and they take these medications, they have a lower risk of the serious side effects like blood clots. So since we started offering the low-dose tamoxifen option, that's a very popular option. Patients can also participate in the TAM gel set study, and we do have patients doing that. And in regards to the low-dose tamoxifen, so we start offering that in December 2018. People can start at standard dosing tamoxifen, 20 milligrams, and if they have side effects, we can dose reduce. Patients can also start at the low dose level and increase the dose if they do not have side effects. Next slide. So in conclusion, there are many risk-reducing options for breast cancer. There's a lower chance of serious side effects if women try these therapies in their 40s and 50s. Tamoxifen lowers the risk of breast cancer while on therapy and 15 years after therapy has stopped. Low-dose tamoxifen may be more tolerable than 20 milligrams. And overall, this field is evolving. So I hope that we will have more preventative therapy options in the future.